Vancomycin-resistant enterococcus was first found in the 1980s, and the infection has rapidly spread worldwide, especially in U.S. hospitals. It is critical that healthcare workers, especially physical therapists, are informed concerning VRE. VRE is an enterococci infection that rejects most antibiotics, specifically vancomycin. Vancomycin is widely used to treat enterococcus infections, but when it rejects the antibiotic, the treatment becomes problematical. Although very serious, the enterococci is less likely to become infectious and cause disease compared to staph or E. coli. VRE affects those with compromised immune systems, such as those who have diabetes, chronic kidney failure, and who are elderly. Enterococci infections can be fatal, but can be even more if it has strains of resisting vancomycin. The following will explain the mechanism of the disease process, transmission, signs and symptoms, treatments, affected groups, preventions, and PT involvement and precautions. Enterococci is normally found in the human digestive system and the female genital tract in healthy people. When the enterococci colonize in a specific area, it can progress to an infection. The infection can lead to disease in the urinary tract, bloodstream, heart valves, brain, and open wound sites. Enterococci are the leading cause of nosocomial infections, including urinary tract infection and bloodstream infection, and furthermore are usually closely related with other pathogens. They are frequently resistant of most antibiotics. Vancomycin disturbs the development of the cell wall and growing bacteria resistance and based on changed targets for antibiotic drug reactions. Vancomycin disturbs the cell wall and growing bacteria resistance is based on changed targets for antibiotic drug reactions, according to Boynton. There are two types of vancomycin resistance in enterococci: Enterococcus gallinarum and E. cassiflavus and E. cassiflavus/E. flavescens. Several genes, including VAN-A, VAN-B, VAN-C, VAN-D, and VAN-E, may contribute to resistance to vancomycin in enterococci. There is still more research determining the gene involvement in making VRE antibiotics. VRE can have various signs and symptoms. There are many people who have colonized VRE and are not infected and therefore requiring no treatment. People that are colonized are difficult to diagnose since there are no signs or symptoms. Colonized individuals could be at risk of developing severe infections when cancer, transplantation, surgery, or advanced age suppress normal host defenses. VRE colonization of bowel, skin, and wounds can continue further with no clinical signs or symptoms of illness or infection. Most groups affected by VRE are ones with weak immune systems. Mostly patients with severe underlying disease or immunosuppression that requires long hospital stays in ICUs in oncology or transplant wards have a higher possibility of colonization and infection. Patients with diabetes, chronic kidney failure, cancer, and immunodeficiency diseases are some examples of those subject to VRE. Those who have been treated with vancomycin with the combination of other antibiotics such as penicillin and gentamicin have an increased risk for infection, especially if their immune system had a prolonged exposure to the antibiotics. Those in long-term care in hospitals that have received long-term general antibiotics, cancer patients who have had thorax surgery or transplant wards have had increased risk for infection. Symptoms of VRE infection on the skin appear red and tender if the infection is on the wound site. If one has a urinary tract infection, then a burning sensation may be present while urinating. VRE is diagnosed by taking stool samples or secretion from the wound site and testing it in a laboratory. The prognosis of VRE can be difficult to determine because the patient infected with VRE can be treated as a normal infection, but will most likely have complications due to other problems. VRE is hard to treat because enterococci bacteria do not respond to most antibiotics. When VRE becomes an infection, precautions for further infections such as isolation are enforced. Linezolid is a newly introduced antibiotic that has had partial success with treating VRE. Linezolid is a synthetic oxalidyne antibiotic active against gram-positive bacteria. It was approved by U.S. Food and Drug Administration in April 2009. Linezolid binds to the 23S ribosome to prevent formation of an initiation complex in protein synthesis, according to Gonzalez. It has reported a 67% successful rate of treating VRE infections with linezolid. Only a handful of cases have been resistant. Resistance is limited when there is proper caution. Physical therapists and physical therapist assistants often treat patients with VRE. They should be first cautioned with working with patients infected by VRE or any other infectious disease. Since physical therapists come in direct contact with patients in contaminated surfaces, they should take all levels of prevention methods to prevent spreading infection to themselves or others. Physical therapy may be prescribed to a patient with VRE for a variety of reasons. The renal or genital areas infected, then physical therapists may educate the patient on urinary incontinence or general strengthening of the pelvic floor muscles. Patients are rarely diagnosed with VRE alone, but they may show signs of general weakness because of their infection. If they have other issues that are not directly related to VRE, their strength might still be affected, and they may benefit from physical therapy. Primarily, physical therapy is necessary for patients with VRE because of post-surgery or wound care, which may expose the physical therapist or physical therapist assistant to VRE. Precautions on preventing infection are imperative for them and other healthcare workers. VRE is transmitted person to person, where the bacterium can survive for months. It mostly is transmitted in healthcare facilities with poor prevention methods for feces, urine, and blood. It can also be indirectly increased via hand contact with open wounds or by touching a contaminated surface where the bacterium can survive for weeks. Controlling the spread of VRE is determined by early detection and prompt reporting of resistance, and the immediate implication of appropriate infection transmission. Many hospitals take precautions by taking weekly rectal swabs for gastrointestinal carriage for laboratory tests. Primary precautions include educating healthcare workers and caregivers of patients to take safety measures in hand washing and awareness in long-term care patients. Hand washing is the primary form of precaution in all three levels of prevention of VRE and any other serious infections. Secondary preventions may include limited type and amount of supplies entering the contaminated room and dispose of all unused items at patient discharge. Certain washing procedures of the environment may be necessary. Commencing lab tests on potentially infected patients on a consistent basis will determine infection quickly and therefore treating it more effectively. Tertiary prevention methods specifically focus on the protection of further spreading the infection. Any personnel entering a site where VRE is present should wear gowns, gloves, shoe covers, and masks and follow the hospital's health procedure to prevention health. Since VRE has increased rapidly in the past couple of decades, it is vital to take charge on the different levels of prevention. Vancomycin-resistant enterococci is an infection that is resistant to most antibiotics, including vancomycin. People with weakened immune systems are especially vulnerable to VRE. Prevention methods are vital for restricting the spread of infection. Physical therapists and physical therapist assistants come in direct contact with patients with VRE and should especially take precautions. In the last 2 decades, VRE has risen steadily in the United States, and with the research of antibiotics for VRE and prevention, the numbers could decrease in the future.